Right, you're on.
Excellent, thank you. Right, well, welcome to this webinar on basic ECGs. And when I say basic, I mean really basic. If you're of a certain age, you would know the Janet and John Book 1. It's when you're starting out on any particular subject. And so for me, we're going to go through this in a really simple way. And the other thing to remember when dealing with ECGs, it's only one piece of a 10-piece jigsaw. When you're trying to work out what's up with your patient, you need to get all the pieces or as many pieces of the jigsaw together as you possibly can. So you're going to look at the levels of consciousness, their pulse rate, their ECG, their blood pressure, their pulse oximetry, their breathing rate, their BM, their peak flow, the past medical history. All of these are parts of the jigsaw that will help you understand what you're dealing with. So we're going to put ECGs in that little box there. So for us, it's just one tool in a bigger toolbox. Right, so to be able to understand ECGs, you've got to understand the build-up of the heart, the makeup of the heart, if you will. Well, first of all, the heart is a mechanical pump. And we've got to remember that a pump that works regularly will work properly. And I've always looked at it this. Your house central heating, when your pump is working properly, your house is nice and warm. When your pump is starting to fail, your house starts to get cooler. And when the pump stops, your house is cold. So putting the heart into that position within the body. Now, we've got to remember that the top half of the heart is the receiving chambers. So we're going to go on to the next slide now. Okay, so we need to recognize those rhythms that need shocking, those rhythms that go into shockable rhythms, and those that are life-threatening. Everything else is a bit of a bonus. For me, when it comes to reading ECGs, and I've been around for a very long time, there's need to know, nice to know, and then stuff to impress other people with. Yeah, so we're going to only cover the basics here. Important to keep your patient as still as possible and as relaxed as possible, because the cleaner the ECG, the easier it gets to read. And basically, we're like playing Cluedo. If you know who the people are, and you know what the murder weapons are, and you know which rooms they're out there, then you can find out who did the murder. And for us, reading an ECG is a bit like Cluedo. Next slide, please. Okay, so here's the build-up of the heart. The atria are the receiving chambers of the heart, so they only have blood delivered to them. So the walls, the muscular part of the atria is only very thin. And we're going to remember that because when we look at the ECG itself, the P wave is only small, and that's because the atria are only small. If we look in the diagram, we can see there Bachmann's bundle. Now, Bachmann's bundle means that the fact that the right and left atria will contract as one. Otherwise, the impulse would come from the SA node, the sinoatrial node, the pacemaker, and it would spread across the heart in a slower period. And so for the atria to contract as one and just give us a P wave, we have this Bachmann's bundle. The atria will push blood into the ventricles, and then the ventricles pump the blood around the rest of the body. So the right atria only pumps blood to the lungs. So that doesn't have a very big muscular mass. But the left ventricle has to pump blood all the way down to the patient's toes. And as a result, the left ventricle is so much thicker and so much bigger. And as a result, it is, I consider it the big bloke. Yeah. So when we go into the bundle branch blocks, we're going to have the right atria is a little bloke, and the left ventricle, sorry, start again. The right ventricle is a little bloke, and the left ventricle is a big bloke. And we'll need to know that later on. In between the atria and the ventricles is a sheet of non-conductive cells. And the pathway between the top and the bottom half of the heart is the AV node. And we're going to consider him as a postman. That is, the SA node sends a letter to the AV node. The AV node, the postman, reads that letter. There's an internodal delay, so the time for the ventricles to fill up completely, and then the AV node passes that message down to the ventricles. Now, above the sheet of non-conductive cells is called supraventricular, supra meaning above in this case. Now, if we went into the patient and we ripped their heart out of their chest and we put it onto the table, not that I advise this, but it would beat on its own. It would have its own intrinsic value. So, in good health, the patient has two feeds to it, the sympathetic nerve and the vagus nerve, one to speed it up, one to slow it down. But it doesn't need those because it has its own intrinsic value, and it will beat without impulses from above. For me, the way I remember this stuff, I'm very simple in this sort of thing. But if we go down into the ventricles, the Purkinje fibers, they will beat without impulse from above between 20 and 40 beats per minute. And it's imagining a drummer. And that drummer is just bang, 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 banging their drum. But because they get messages from the SA node, which come down at 60 to 100 beats per minute, he takes on that rhythm. So imagine that you have a drummer, but the drummer beats faster because he gets faster impulses. Okay, moving on to the next slide. Here we have the QRS complex. The P wave, the first little bump, is the atria contracting or depolarizing, as they like to call it in big school. This is then the PR interval is the next bit, and what we have here is the atria pushing down blood into the ventricles. If you like, it's the ventricles filling up, and within that time is the internodal delay, which is 0.1 of a second. And that's important because for us, it's the time that the ventricles fill up properly. The QRS complex is the ventricles contracting as one. Here, we do not see the atria relaxing or repolarizing because the ventricles are so much bigger in muscle mass, they hide the atria relaxing. The T wave is the ventricles relaxing. And then the ST segment, which should be isoelectric, is a pause. So the ventricles contract, QRS complex, pause, ST segment, and then they start to relax, which is our T wave, which should be positive, which is upright. And important for us later on when we're looking at ST depression and ST elevation, the ST segment tells us whether a patient is depressed or elevated, and we'll look at that later on. Next slide, please. Paper depends on the machine you're using, but it goes through at a set rate, and that will help us later on. The thing to remember that 5 small squares is 0.2 of a second, and 5 large squares is 1 second. Now that's going to help us later on when we're looking at whether the patient's rate, but of course you can always look at the machine and take a pulse. Next slide, please. Now, When we look at the paper, what we can see is vertical rising is the actual amount of muscle mass that's being used. So vertically, it's the amount of muscle that's moving. Horizontally is time. So it's the time something takes to happen. And that's important for us later on. So it's important to remember what those little squares are about. Next slide, please. So this is the 11-point plan, and I've condensed it purely for the purposes of actually putting it on the screen, otherwise it's too much. So first of all, we've got to look at what is the rhythm. Now, the rhythm's either going to be regular or irregular. The Americans like a thing called irregularly irregular. Now, in my head, that's just irregular. But it could be that the patient's having paroxysmal sessions where they have bouts of, and I suppose that's where that fits in. To work out whether it's actually regular, then we can get a second piece of paper, line up the R waves, move it across one complex, and if they all line up again, it's a regular beat. And of course, we talked earlier about our central heating system. A pump that works regularly will give us a warm house, and a pump that beats irregularly will give us a cooler house. So what is the rate? The rate's important because it's the time that heart takes to fill up. We can look at bradycardia, the slow heart rate below 60 beats per minute. And we're going, oh, no, this patient's sick. But part of our questioning is history. This patient may be an ultra marathon runner. Their normal resting heart rate could be 35 beats a minute regularly. And that's what there is. So we're going to have a slow rate. We're going to have a normal rate, 60 to 100 beats per minute, and a fast rate, which is tachycardia, which is the fast heart rate above 100 beats per minute. So the questions we're going to ask is, are there P waves present? Well, we've already seen that we've got a little bump. And if that little bump is present, this is the atria contracting. Are all the P waves the same? Now, if the P waves are different, this is because the impulse or foci is coming from a different place. And later on, we can have later on, we can look at the fact that in atrial fibrillation, they're all over the place. So we'll look at that later. Is there a P wave before every QRS complex? If there's a P wave and then there's QRS complex, we can know that the electrical pathway of the heart is working, but there may be other problems later on. Is there a QRS complex after every P wave? Well, in third degree heart block, which is complete heart block, which we're going to look at later, there aren't. And that's because there's a disassociation in between the atria and the ventricles. We'll have a look at that later on. We're going to look at the PR interval. And this is the time where the heart starts to contract, the atria contract, and then the ventricles start to contract. This is important for the time for the heart to fill up. And so we would look at 3 to 5 small squares, 0.12 to 0.20 seconds, which includes the internodal delay for the time of the heart to completely fill up. And later on, we'll look at heart blocks where there's a problem. Is the QRS complex of normal duration? And that should be 1 to 3 small squares, or 0.4 to 0.20. 12. So here, if the QRS complex is 1 to 3 small squares, normal conductivity is happening. If it takes longer than that, it is broader or wider, there's something not right. And there could be a bundle branch block, or it may be a ventricular rhythm. But if the QRS complex is normal, then you're pretty sure that it is supraventricular. The impulse has come from above. Is the ST segment isoelectric? Is it running straight across the screen? For me, the way I remember it, if the ST segment is depressed and it's sad, it's because it's not getting enough oxygen. And this is our angina or ischemia. And if the ST segment is elevated, it's because it's going to heaven and it started to die. And that's just little ways I remember this stuff. The next question is the T wave normal? It should be positive, it should be upright. If the T wave is inverted on upside down, this is because if ventricles contract abnormally, they relax abnormally, and so you would get an inverted T wave. That might be because there's a heart attack or some problem going on, or it may be an old heart attack and it's just resident there. And from that, or asking these questions, we would then come to where is the pacemaker site. So our pacemaker could be the SA node. It could be just within the atria. It could come from the AV node, or it may come from the ventricles themselves. It may be the fact the patient actually has an electrical pacemaker. And there's a little tale for us later on when we look at pacemakers, so we don't get caught out. Moving on to the next slide, thank you. So let's have a look at the normal values in lead 2. Now we use lead 2, part of Eindhoven's triangle, which runs from 11 o'clock to 5 o'clock on a clock face, and that's because most people's hearts are inclined in that direction. We are not going to cover axis deviation in this session because that's for cardiologists, not for ambulance staff. So when an impulse goes towards the electrode, you get a positive deflection. It goes upright. If it is going away, then it becomes negative. That is, it falls over. So we're looking at a normal standard QRS complex here. So we have a P wave present, happy days, it is positive, that's good news. The PR interval is of normal duration, 3 to 5 small squares. Our QRS complex is of normal duration, 1 to 3 small squares. Our ST segment is isoelectric and the T wave is positive. So now we can be in a more relaxed state, unless obviously our patient is not breathing and has no pulse because they're in PEA. So that's not a good thing, is it? But let's say our patient is conscious breathing and talking to us and we see this. This will help us relax a little bit. Moving on to the next slide. So let's have a look at these slides. This is normal sinus rhythm. Sinus meaning it's actually coming from the sinoatrial node. When I put this presentation together, it was down to the fact that I was going to be with you and I could actually point to the screen on the electrical system of the heart, but we'll have to work around that. Here, we're looking at a patient at rest. Ignore the V5 bit. And so we have a look at this. Well, first of all, what is the rhythm? And that to me looks pretty regular, and I'm fairly happy that that's a regular beat. What is, sorry, yeah, what is the rate? The rate, we'll call that normal. And so are there P waves present? And we can have a look there, and those P waves, the little first bump, looks perfectly okay to me. Is there a P wave before every QRS complex? Yes, there is. And is there a QRS complex after every P wave? Yes, there is. What is the PR interval? And we can have a look there, and we're quite happy that looks like 3 to 5 small squares. Does the QRS complex look normal? It's 1 to 3 small squares. Yes, it does. Is the ST segment isoelectric? Yes, it is, because it runs right through. It's not obviously depressed and it's not obviously elevated. And is the T wave the right way up and greater than the P waves? Because obviously P waves are little muscle mass, ventricles are bigger muscle mass. And we look at rest there and we can say, yes, I'm quite happy with that ECG. But when we look at the lower one, the exercise, well, first of all, the rhythm looks okay, but the rate is fast. So we've got a faster heart rate, and obviously you're going to take the patient's pulse and look at the monitor and check what the rate is. But we can see that this patient has a fast heart rate. It is a regular beat. That looks perfectly okay with me. We can see discernible P waves, but because of the speed, the P wave is encroaching the T wave. And so here it's purely down to the speed of what's going on. So we've got a P wave present. There's a P wave before every QRS complex. There's a QRS complex after every P wave. The PR interval is normal. The QRS complex is normal. But we can now see that the ST segment is depressed, and that's because the heart is not getting enough oxygen at the time. And it may be that this patient is suffering from angina on a stress machine. The T wave is the right way up. So we can happily say that normal sinus rhythm is occurring, but the patient has a depressed ST segment, and so we're going to do the rest of our checks. Next slide, please. Here we have bradycardia, a slow heart rate. We can see straight away that the gap between the QRS complex is much normal than we would normally see. The rhythm is regular. There are P waves present. There's a QRS complex after the P wave. There's a P wave before every QRS complex. The PR interval is of normal duration. The QRS complex is of normal duration. The ST segment is isoelectric, and the T wave is the right way up. So we can say here that normal sinus rhythm is occurring, but at a slow heart rate. And as I said earlier, it may be normal for that patient. You need to take a big past medical history. Moving on to the next slide. Here we have sinus tachycardia. So above 100 beats per minute, we can see that the fact that the heart is beating very fast, but it's obvious that it is a regular heart rate. So that's good. Are there P waves present? Yes, they are, and we can see them. Is there a P wave and are they all the same? Yes, they are. Is the P wave before a QRS complex? We can see that. Is there a QRS complex after every P wave? Happy days. PR interval looks good. QRS complex looks good. ST segment looks good. And the T wave's the right way up. So we can say happily that this is originating in the sinoatrial node, and as a result, it is just a fast heart rate. And that could be the fact that the patient's excited to see the ambulance crew. Next slide, please. Okay, now supraventricular tachycardia. This can happen in young people. And here's a quick cautionary tale for us. I remember many, many, many years ago, we had a situation where we went to a call. A 23-year-old lad was stood outside a post box. He said, I've got chest pains. I went, really? Back of the ambulance, sit on the left. Oh, I suffer from SVT. And I thought, well, you're not going to grab that out of the sky. Popped him onto the stretcher, wired him up on the heart monitor, and there, right before our very eyes, is supraventricular tachycardia. So don't get caught out. Supra means above. So now when we look at this rhythm, it's fast, so it's a tachycardia. It's regular, so that's a good thing. But there are no discernible P waves. So we can ignore some of the other questions. So the next question is the QRS complex of normal duration, 1 to 3 small squares? Oh, yes, it is. Is the ST segment isoelectric? Yes, it is. And is the T wave the right way up? And because we can see normal conductivity is occurring, we can happily say the speed of what this heart rate is beating is the atria are contracting, but we can't see them because they are buried underneath the T wave. So supraventricular tachycardia is normal QRS complexes is the clue for us there. Next slide, please. Here we have atrial flutter. Here, the atria, instead of having the impulse coming straight away from the SA node, it's occurring in various places of the heart. So, what is the rhythm? And it looks regular. What is the rate? It's fairly slow. Are there P waves present? Yes, they are. Are all the P waves the same? Oh no, they're not. So that's telling us that the foci, the impulse is coming from various places. Is the QRS complex of normal duration? Yes, it is. And there are T waves present, and they're the right way up. So this is telling us that this impulse is coming from the atria in some place, but it's normal conductivity going through the rest of the heart. And so this is atrial flutter. Next slide, please. Atrial fibrillation. Now this is a bad one because this causes problems for our patients. So what is the rhythm? Well, it's irregular, and we can see that straight away. What is the rate? Well, it's hard to tell, isn't it? Because it's irregular. Are there P waves present? Well, sort of. Are the P waves all the same? Oh, no, they're not. Are the P waves before QRS complexes? Most of the time. QRS after P wave? Most of the time. But we can see that the QRS complex is normal, as in 1 to 3 small squares, and the T waves are present. So this tells us that the impulse is coming supraventricular, above the ventricles, and so the reason we have an irregular heart rate is because the atria are quivering, fibrillating, and the AV node, the postman of the heart, is getting so many letters irregularly, he's having difficulty reading that address before passing it on. And so because he's snowed under with the amount of impulses he's getting, he sends a letter, and then there's a gap, and then he may send another letter. Oh, and then he sends another letter. Now, the reason this is a problem is that because the blood is sloshing around in the atria, mural clots occur, and they can go and visit the patient's brain and give them a stroke. So AF, should I say, atrial fibrillation occurring in a patient, generally in the elderly, quite often in danger of having a stroke. So this patient may be on aspirin or on blood thinners, so those clots don't occur. Next slide, please. This is a bit of an impress other people, and that is the bifid P wave. And what's happening here is because of heart failure, right or left heart failure, it doesn't really matter. Here we have a situation where in normal, the atria contract as 1. In RAE, which is right atrial enlargement, what's happening here is because of heart failure, the muscle mass on the right side is bigger, and so we get a funny shaped P wave. And of course, then we have left atrial enlargement, and of course the bottom has the two going on together. But that's just an impress other people stuff. Moving on to the next slide. High nodal junctional rhythm. Now, whether you see this on a daily basis is another question, but we need to know this stuff, because if you don't know what it looks like, then you might miss it. Here, the AV node is sending the impulse out. So the SA node hasn't got involved. The AV node, because it's not getting any impulses from the SA node, this will be more bradycardic, slower if you will, because it is now the postman, the AV node, sending the message out. So what is the rhythm? It's regular. What is the rate? It's a bit slower. Are there P waves present? Yes, but they're upside down. And that is because in lead 2, the impulses are moving away from the electrodes, and as a result, it inverts. The impulse then goes down the bundle of His into the right and left branches, and so our QRS complex is of normal duration. The ST segment is fine, and the T wave is the right way up, because if ventricles contract normally, they relax normally. So hopefully you can see there the upside down P wave, which tells us this is a junctional rhythm. Next slide, please. Here underneath, we can see the fact that the high nodal junctional rhythm has an inverted T wave. Mid nodal, you don't generally see it. And then if it is a low nodal, you would have the T wave upside down after the QRS complex. Next slide, please. And here we have the low nodal junctional rhythm, because the impulse is now going from the AV node down the bundle of His into the right and left branches, and our QRS complex is of normal duration, but the impulse is also going up into the atria, and as a result, the ventricles contract and then the atria contract, and as a result, this patient's not going to be very well at all because things aren't happening how they should do. Next slide, please. First degree heart block. Here we can see that we have a regular rate and rhythm. We look for P waves. There are P waves present, but they're up against the T wave. This is because in this particular case, this is a massive first degree heart block. So are the P waves present? Yes, they are. Are they all the same? Yes, they are. Is there a P wave before every QRS complex? Yes, they are. Is a QRS after every P wave? Yes, there is. What is the PR interval? And we can see blatantly, obviously, that the gap is greater than 3 to 5 small squares. The QRS complex normal duration, ST segment's fine, T wave the right way up. And so we can quite happily say here, the postman, the AV node, he is getting his messages from the sinoatrial node, but he's taking a long time to read that letter, but he passes the letter on, and he's doing that on a regular basis, and hopefully that's obvious to you. Next slide, please. We'll have to have a drink. Now, Morbitz type 1, Wenke back. Here the QRS complex is walking backwards from the P wave, and so our postman, if you like, every time he gets a letter from the SA node, he takes longer to read it, and then he forgets to pass it on. And in type 2, he gets the letters on a regular basis, but occasionally he forgets to pass it on. Next slide, please. Third degree heart block. Here we can see straight away that it is a slow heart rate, so that's going to be worrying. It's regular, so that's okay, I suppose. Are there P waves present? Yep, happy with that. Is there a P wave before every QRS complex? No, there is not. Is there a QRS complex after every P wave? No, there is not. What is the PR interval? Well, it's hard to tell because there's not always a PR interval, so we'll ignore that. Is the QRS complex of normal duration? Oh, no, it isn't. So where we see the big complexes, we can say that they are ventricular. Is the T wave normal? No, it's upside down because ventricles that contract abnormally relax abnormally. And so we can say here the postman is dead because the SA node is sending impulses towards the ventricles. They are not receiving the information, and our drummer, who's in the ventricles, who beats between 20 and 40 beats per minute, is going, well, I'll just beat the drum myself. And so there is disassociation between the atria and the ventricles. This cannot go on because our patients will then go into a shockable rhythm. So this is VBAD if we see third degree heart block. This patient cannot do this for very long at all. Moving on to our next slide. The bundle branch blocks. Now, remember I said that the right ventricle pumps blood to the lungs, so that's our little bloke. The left ventricle pumps blood all the way down to the patient's toes, and that's our big bloke. Now, the impulse comes through the heart. We can see that there are P waves present. We can see the the PR interval's fine. But now when we look at the QRS complex, it is broad and notched. And that is because the left ventricle starts to contract and then the right ventricle catches up. So here we have a situation where the big bloke can make the little bloke work, but it just takes a little bit more length of time. And we can see there that the T wave is upside down. And that is because if ventricles contract abnormally, they relax abnormally. Now, sometimes this is called rabbit's ears, but we can see straight away that there is a notch. Patient may be able to tolerate this. It's interesting to know, but it's also worth knowing because we need to know on the next slide the difference. So we're moving on to the next slide, please. Here we have left bundle branch block, and as we know that this can be indicative of a patient having a heart attack or an old heart attack. And here we have a situation where the right side of the heart is going to struggle to make the left side of the heart work. And so our QRS complex is going to be much broader and wider. And so we see there the notches appearing, and that is because the right ventricle starts to contract and then it causes the left ventricle to contract, and that all takes time. And of course, if ventricles contract abnormally, they relax abnormally, and we have an inverted T wave. Next slide, please. Ventricular tachycardia. Here, no P waves present. We have a fast rate, it's regular. But first question has to be, is our patient breathing and do they have a pulse? Because if they haven't, and we see this on the screen, it's defib time. And I think, dealing with patients, the easiest patient that you ever get to deal with is cardiac arrest, because you can then deal with them with a set protocol. It's working out the other stuff that's hard. So here we see broad QRS complexes, no P waves present, and so we can say, yes, this is a ventricular beat. It's tachycardic because it's above 100 beats per minute. So the question is, does it have a pulse? Does it not have a pulse? And if it's got no pulse, we're going to zap it. Next patient, please. Here is slow VT. The impulse is coming from the ventricles. We see no P waves present. QRS complexes are broad and the T wave is inverted. This may be a regular beat on a patient. This is a benign beat, and that is, it may not do the patient any harm whatsoever. They may have been born with this. No P waves present, QRS complex broad, T wave inverted, but it's at a slow heart rate. Nothing to really worry about if your patient's tolerating it. Next slide, please. Ventricular fibrillation. Here we've got chaos going on. There's no P waves present. There's no rhythm. There's no rate because you can't tell anything. Our patient, if they are not breathing and have no pulse, we're going to shock them. And I think this is a nice, easy one to deal with because we've got chaos going on in the heart, and the only way forward is defibrillation in this patient. Next slide, please. Asystole, the flat line. A before anything means none. Systole is the contraction of the heart. First question is the patient breathing? Do they have a pulse? Check the leads and make sure your mate hasn't cut through one of the leads when you've been wiring the patient up. And obviously, a flat line is going to get CPR'd. Next slide, please. Premature atrial contractions. This can come from too much stress or drinking too much coffee or naturally occurring phenomena. So let's look at this using our 11-point plan. What is the rhythm? Well, we can see that it is slightly irregular. What is the rate? Well, it looks normal rates for me. Are there P waves present? Yes, they are. Is all the P waves the same? No, they're not. We can see there the second impulse on the premature atrial contraction is a funny shaped P wave. Is there a P wave before every QRS complex? Yes, there are. Is there QRS after every P wave? Yes, there are. Is the ST segment isoelectric? Yes, it is. Is the T wave the right wheel? Yes, it is. But we can see behind the second complex a pause. And that is because if the heart gets an extra beat, whether it's atrial, junctional, or ventricular, the heart will always pause before beating again. So if you like, in our second complex here, because the atria are upset, they've sent in an extra beat, and as a result, the heart has to have a little rest, and hopefully there we can see a compensatory pause. Next slide, please. Here we have ectopics, impulses that come from a situation whereby there's upset in the heart. And in the top one, we can see that in most of the complexes, P waves are present, QRS complex normal duration, T wave right way up. But there, smack bang in the middle, is a broad complex QRS complex with an inverted T wave. This is because the ventricle has thrown in an extra beat, and behind it, there's a compensatory pause. Because as we know, if ventricles contract abnormally, they relax abnormally. If we look at the bottom one, the overall rhythm is normal sinus rhythm, but we can now see, obviously, there's a couple of extra beats there, but the ventricular beats are misshapen. They're not following the same pattern. So we can say here that this patient's suffering from multivocal premature ventricular contractions. Remember the compensatory pause there. The more of these, the sicker the patient, the greater the chance of going into VF. Well worth spotting. Next slide, please. Here, remembering our drummer in our ventricles beating at 20 to 40 beats per minute. Here, the first part of the slide, normal sinus rhythm is occurring, but now an impulse is not being passed on and the ventricles kick in under their own right. And as we can see, the second half of this slide, the ventricular escape beats. And an escape beat, we have a pause before the heart kicks in again. And so, if you like, it's the reverse of the last lot. And so the heart goes, hold on a second, I've not had a message from above. Maybe the postman's dead. I'll start beating on my own. And so we can see now that the broad, complex ventricular beats start occurring, and they're bradycardic. Next slide, please. Looking at heart attacks here and ST depression, they look for the J point, and in the second one, which is the important one, we're going to have a look at heart attacks in a second, we can see that the J point is below the isoelectric line, and so our heart is depressed because it's not getting enough oxygen, as in angina. Next slide, please. Here we have ST elevation. As a paramedic, when we see this, we go, hoo-hoo, at least we know what we're dealing with here. A barn door ST elevation, you know where you're at. Now, somebody asked a question the other day when I was delivering this, but what about a high takeoff? And I'm going to say this to you. You might not agree with me, but I'm going to say it anyway. If it looks like a duck, it walks like a duck, and it quacks like a duck, it's a duck. Remember, at the end of the day, you're going to take that patient to hospital where they will have blood tests to assess whether the patient's having a heart attack or not. So you're going to take the best option, the safest option. If you see that, don't get too complicated, yeah? ST elevation with crushing chest pain, pale, cold, clammy, sweaty, blue around the edges. Blue is never a good colour in a patient unless it's Papa Smurf. If they're not tolerating this, you're going to take them to hospital. So don't get hung up on this high takeoff thing. Moving on to the next slide, please. Here we have pace beats. On the top slide, we can see that the pacemaker kicks in, and we've got it kicking in just before the P wave. And this tells us that this patient has got an atrial pacemaker. And you can see the spike before every P wave. The QRS complex is normal, the T wave is normal. So electrical conductivity is occurring, but we can see here that this patient has a pace beat. If we look down below, we can see now that there are two spikes, one before the P wave, one before the QRS complex. And this is called dual chamber pacing. Obviously, this patient's got a very sick heart, and we see P waves just after the spike, and then we have a QRS complex after the spike. Now, here's a little tale for us, because I always like to throw a little tale in now and again. Many, many years ago, I remember we used to have a GP in my old patch, and he had a green light on his car because he was a frustrated paramedic, and just wasn't clever enough. He just had to be a GP, and he would turn up at jobs just before us. And so we turned up at this job one day, and he met us as we were walking up the drive, and he says, Steve, the patient has passed away. I've informed the family. I said, oh, okay, doc, that's fine by me. We'll see you then. And he went, oh, no. Come on, bring your heart monitor with you. Bring your heart monitor in. And I went, really? You've just told the family he's dead? No. Anyway, so we wired the patient up, and on the screen, boing, boing, boing. And he went, oh my God, I've told the family they're dead. And I said, calm down, doctor. It's only the pacemaker, and this will occur for the next 10 years. Anyway, there's a little tale for us. Moving on to the next slide. So we have covered basic ECGs. Everything else is a bonus. Going into the likes of Wolf, Parkinson, White, where there is another pathway in between the non-conductive cells and the P wave is flat up against the QRS complex. That's for impressing people, yeah? So we'll save that for other courses. If you want to read 12 lead ECGs, then you need to get further into the story, and that may be for other people. Now, you can get my book by downloading it from my website. I can't believe I'm saying this. If we visit www.steveevans-mbe.co.uk, the link's there, or if you visit SP Services website, you can download it from there. Okay, so we're now going to close the recording down